Hello, welcome everybody. So fun to see all of you. So many beautiful people in pink who are a bit fallopian and so many smiling faces. So really wonderful to see all of you here tonight. I'm so looking forward to sharing the salon with you on this beautiful sunny day. So after this lecture, we will go to the other side and we'll be able to go stand in the sun and have the beautiful view of London. But first, we have a very special treat, who is called Rayna Rapp. And I was just playing the song, The Baddest of Them All, because Rayna is the baddest Reaper scholar of them all. So we are very happy and very honored to have you here. We are mostly so honored to have this iconic scholar of reproduction with us because she's such an incredible oeuvre, such an incredible career. She flew all the way from New York to be here with us and to share her reflections on the situation, on reproductive politics, and as she calls it, stratified chaos in the United States at the moment. And I think I speak for all of us when we say that we're so happy to welcome you to London and so keen to listen to you. I want to pay tribute for your incredible work over the decades and to celebrate everything you have accomplished in your inspiring career. So as many of you know, Rayna has done pioneering work on reproduction, focusing on selective reproduction, which she explores in her influential book, Testing Women, Testing the Fetus, and as well has focused a lot on stratified reproduction, which she will be developing today, which is a concept she developed with her graduate student, Shelley Cohen, and played a central role in her iconic anthology called Conceiving the New World Order. She has a long-standing academic partnership with Faye Ginsburg, and it does feel a bit cruel to see you without her, but you also shine in your own right. And they have just published an amazing new book called Disability Worlds. I haven't read it yet, but the book does reflect Rayna and Faye's long-standing interest in disability studies and its intersection with reproduction as well. This latest book was just launched last week, and it sounds like it was an incredible, heartfelt event, moving some of its attendees to tears. And this is what scholarship should do. It should move us, it should move the world, it should say things and change things, and it should be thought but also felt enough to give us the drive to amplify our voices and the voices of those that should be heard in order to make a more just world. And this is what Rayna has done throughout her career, not only in her research, but it's also reflected in many amazing articles, which you can find on the celebration table in the Reproduction Salon later on, but also because she approaches her work with warmth and kindness and curiosity, which I have had the joy of experiencing already. But I know that her kindness and generosity to her students is wonderful and is reflected in the enduring work relationships that she builds with them. Her warm personality is also what makes her such an appreciated scholar across the board. And indeed, she is very appreciated here with us in London. When I told people she was coming to the salon, the response was often like this. The eyes were widening, opened by a wow sound, and then often people smiling. And today, we just want to say what a good life and what a good work you bring to the world, Rayna, to elicit such wonderful responses. And today you will also respond to a situation that was starting to unfold at the Supreme Court 2 years ago. I mean, of course, it's got a much longer legacy. But right when we had our first salon 2 years ago, we were talking about Roe v. Wade being overturned. And now that that has happened, and now that there's an aftermath of that, who better than Rayna Rapp to reflect on that? So we're very keen to hear what you reflect on this as a cherished legend in the field who has had a finger on the pulse of reproductive politics for decades. So look at all these beautiful people here ready for you and for your words. Let's not keep them waiting. Everybody, Rayna Rapp.
Oh, Lucy, thank you for that wonderful introduction. I can't actually be legendary when I'm also this short, so forgive me while I peer over the lectern at you. Thank you, Lucy. Thank you, Anne Pollock. Thank you, everybody who brought me here today to share the bad tidings from America with you. The title, alas, says it all, especially as the frantic New York and US news cycle means that an audience as well-informed and committed to scrutinizing the socio-cultural relations of reproduction as this one has already sampled much of what I've been able to glean in the last few months since this generous invitation to participate in the Reproduction Salon was preferred. The national and state-by-state situation that I have labeled chaotic, confusing, and cruel is, by definition and intention, unstable. State level and federal judicial rulings change day by day. As most of you know, the US governance system is federal with powers of legislation, regulation, and enforcement apportioned across both the 50 states and the federal government. Regulation of public health, privacy, freedom of speech, and equal protection of the law exists at both levels of governance and are very much contested, especially in light of Donald Trump's success in appointing 3 extremely conservative justices to our Supreme Court, or SCOTUS, which adjudicates disputes across state national jurisdictions. There, anti-abortionists and right-wing Christian nationalists had long been preparing for the day when Roe v. Wade, guaranteeing a constitutional right to abortion that superseded state laws to the contrary, was overturned. That ruling, Dobbs versus the Jackson Women's Health Organization, was handed down in June 2022. Lucy just referred to it, immediately triggering huge demonstrations and also total bans in the red states that were anti-abortion, calling on legislatures in other states to remake their abortion laws. It continues to roil through my country, state by state, where some anti-abortionists have quickly renewed efforts to escalate potential criminalization of healthcare providers as well as pregnant people and anyone who supports them so that they cannot even counsel abortion. Or possibly, this one's still up for grabs, even use interstate travel to seek the procedure. While other states have passed what are called shield laws to protect healthcare providers from long-distance extradition and prosecution if and when they deliver abortion-inducing medication via telemedicine or even help someone to manage a miscarriage. Unstable, chaotic, and confusing indeed, and devastatingly cruel, especially to the most vulnerable. Next slide. And sometimes providing a glimpse of comedic farce beyond all reason as well. During the weeks in which I've been gathering resources for this talk, Alabama's frozen IVF embryos came and went as living children. If you dropped them in the lab and their test tubes shattered, you might be charged with involuntary manslaughter, according to a ruling by the Alabama State Supreme Court. While emergency state-level legislation quickly undid this absurdity under scrutiny of national horror and derision, this strategy for declaring the personhood of frozen embryos will surely be fine-tuned elsewhere, even as many right-wingers are testifying to the blessings of their children born via IVF. At virtually the same time that this was going on, the Florida State Supreme Court issued its own surreal tug-of-war rulings, upholding the ban on abortion at 6 weeks, while approving a proposed constitutional amendment allowing access to termination before viability, roughly 23 weeks, to appear on the state's fall ballot. This guarantees Florida's status as a money sponge and object of election cycle hysteria between now and November. Yet everywhere it has been on the ballot, abortion has netted significant victories for the Democrats and independents. The woman's vote, so-called, presumably pulls sympathetic non-women into the voting booth in the wake of admirable, consistent, and creative local activism. Kansas, as in what's the matter with Kansas, it's a famously conservative state, Kansas had the honor of passing the first post-Dobbs constitutional amendment proclaiming and protecting reproductive rights. Kansas's efforts echo through many similar actions in 7 other states where voters have approved abortion rights measures, including 4 in California, Michigan, Ohio, and Vermont, that wrote abortion rights into their constitutions. Citizens in Missouri and Alabama, deeply conservative states, also recently succeeded in mounting constitutional amendment initiatives that require voters to approve or disapprove the right to reproductive liberty in their respective venues. Supporters of a South Dakota abortion rights initiative submitted far more signatures than required to get on the ballot this past May 1st, where uber-conservative legislators are trying to stop it being put to state vote in the fall. So there's a real challenge going on. The signatures were submitted on the same day that the Arizona legislature approved repeal of a long dormant ban on virtually all abortions written in 1864 before Arizona became a state, while leaving in place a law banning all terminations after prenatal diagnosis. Anti-abortion forces are incensed and want the Arizona Territory law reinstated. This contest continues currently in the courts. And on the same day, that is the 1st of May, Florida's 6-week ban on abortion went into effect, closing down what had been a hub for abortion care when its prior 15-week limit drew care seekers from several neighboring states, banned states in the South. And the confusion is ongoing, even when abortion rights are restored or protected after legislative and judicial battles at the state level. Ohio is a perfect example. Virtually banned by state legislation in 2019, a huge referendum initiative after Dobbs led to placing abortion rights into the state constitution in 2023, where it was promptly contested in state courts, where it was declared valid just recently in 2024 with 2 minor provisions invalidated. This is a huge victory, but many healthcare providers and pregnant patients are still uncertain of the, in fact, rights-preserving outcome of these multiple rounds of voting and court battles. Those residing outside the US might well join those of us on the inside in finding all of this very confusing, and that is how the US government system functions. Campaigns over rights are commonly fought in legislatures and courts at the state level, where tactics often include efforts to pass a constitutional amendment to the state constitution or ballot initiatives for protection of reproductive autonomy, liberty, freedom. Language is deeply important and linked to particular state constitutions, of which there are, of course, 50, each with a somewhat different discursive framework. And if this weren't complicated and cruel enough, it's important to highlight that the movement to ban or severely curtail abortion rights is deeply linked to wider conservative efforts to limit the voting rights of those most likely to support other liberal policies: racial, ethnic minorities, low-income voters, especially in cities with diverse populations, while special measures in some states also target rural or disabled voters. As the Supreme Court agrees to hear selected state cases that champion these voting restrictions, their decisions all hold implications for all 50 states of us. Next slide, please. This is SCOTUS, the Supreme Court of the United States. We await SCOTUS's decision challenging many, many laws that are totally consequential to this discussion. The first is the FDA, Federal Drug Administration jurisdiction over the safety and thus the availability of mifepristone, the most common abortion medication. A second case, now in SCOTUS's hands, challenges Tennessee's highly restrictive abortion ban law, arguing that even when amended to allow narrow exceptions supposedly to save the mother's life or, quote, impairment of her major bodily functions, end quote, the law totally constrains the physician's decision-making ability, leading to endangering and damaging pregnant women under emergency conditions. And then there is the Emergency Medical Treatment and Active Labor Act, EMTALA for short. passed by the US Congress in the 1980s to ensure patient access to emergency medical care and to prevent the practice of patient dumping from private to public hospitals without consideration of their medical condition or stability for a transfer, so they could die in the transfer. The federal government is now using EMTALA, federal legislation, to challenge Idaho over its legislation preventing emergency abortions in emergency rooms if somebody comes in and needs one. Slide 4, please. The federal case in part reads, that means a pregnant woman could arrive at a hospital urgently needing essential care and, instead of offering, this is the language of the law, such treatment as may be required to stabilize the medical condition, the hospital would have to let her die. EMTALA's stabilization mandate cannot be such an empty promise. Next slide, please. Let me explain this one. One of the Supreme Court, the liberal Supreme Court justices, Elena Kagan, asked in the questioning at SCOTUS, so that means it's become transfer is the appropriate standard of care in Idaho, but it can't be the right standard of care to force someone onto a helicopter. Parenthetically, the Medevac insurance groups are doing a booming business in the red states where people are buying insurance in case they have to be medevaced out at enormous cost. It's absolutely harrowing. Although not yet on the SCOTUS docket, First Amendment freedom of speech challenges posed by state restrictions outlawing physician-patient conversations about abortion care out of their state are now making their way through the court system. That is, many of the anti-abortion forces are trying to contest and outlaw the free speech so you can even talk about abortion in another state and help your patient to get there. All of these cases were triggered by Dobbs, and all of their SCOTUS outcomes hold immense consequences across the states. Stay tuned, the situation will remain unstable. From where I stand, the overview of Dobbs is dreadful. Around the country, 1 in 3 women of reproductive age now lives in a state with strict bans on abortion. There, 1 in 7 women has either needed an abortion or is close to someone who does. And the exception clauses to restrictive laws are carrying on the dangerous confusion. In Texas, for example, there are 3 abortion restrictive laws on the books, each with narrow, vague exceptions and draconian penalties for misinterpretation, leaving healthcare medical providers confused, indignant, frightened, and more. In Alabama, the ACLU, the American Civil Liberties Union, reported in early May that healthcare providers had been forced to stop offering vital information, counseling, and practical assistance to their patients seeking abortion care out of the state in fear of potential felony prosecutions after the state Supreme Court decision and its legislative flip-flops. They no longer have confidence in what they are allowed to say. In ban and highly restrictive states, relatively common conditions like preterm amniotic sac rupture, or less common ones but life-threatening ones like ectopic or molar pregnancies, now send providers into mandatory ethics committee meetings, peer consultation hearings, and more. And while they seek professional guidance, risk of infection and illness, even leading to maternal death, is growing. And the long-term consequences for the future of OB/GYN medicine are also disastrous. Among students and residents, simmering anger over bans is growing. Longtime faculty in medical colleges fear the result will be a permanent reshaping of American medicine, driving new doctors from red states to escape limitations and legal threats, or to protect their own reproductive options. That would reduce the number of physicians available not just to provide abortion, but to take care of miscarriages, but deliver babies and handle all the unpredictable risks of pregnancy. Next slide, please. Of course, the demise of Roe had long been anticipated, and many important organizations had been working on these court cases trying to prevent the loss of abortion rights. The Center for Reproductive Rights, the American Civil Liberty Union, Planned Parenthood Action Funds, all have supported test cases over the previous decades as they move from state to federal courts, and all provide backup, albeit selectively, to local legal teams defending clinics, providers, and patients. All these organizations received an outpouring of donations after Dobbs was declared, and they have a vast amount of work to do. Next slide, please. Beyond legal teams dueling across the states to the federal level, it is important to highlight that abortion procedures had already shifted, first gradually and then very rapidly, from surgical to medication technology for early-term pregnancies. In 2022, 53% of terminations used pharmaceuticals. By 2023, a year later, that number was 63%. And this only includes those reported by medical facilities. More undoubtedly have taken place through informal routes. These are near impossible to track. The technicon of the pharmacy, exactly, along with feminist ingenuity. Consider the remarkable work of Plan C, a public health creative campaign started in 2015 by a small team of veteran public health advocates, researchers, and social justice activists and digital strategists. Plan C transforms access to abortion in the U.S. by normalizing the self-directed option of abortion pills by mail. Could we see the clip?
I wouldn't lie to you, they got a pill that you can take after you get pregnant, and it will automatically abort the child.
At the beginning, it was just trying to make clear that these pills existed, that they were safe, they were effective. Abortion pills are available by mail, it's a thing.
And of course, people said, you can't do that. That's illegal.
There is no longer a federal constitutional right to an abortion.
If I can't get an abortion, I'm gonna kill myself. And then she hunks up the phone. We all went to the post office just now to drop something off. Sounds like candy and or beads.
Go to this website, send money through this portal.
My brain went, just go buy black market abortion pills.
Mobilizing is really hard when you're scared and you're censored.
I get frustrated by everybody trying to follow the rules instead of what really needs to be done.
I'm not going to be stopped or hindered by the law one way or the other.
It's like we're running a drug cartel in order to help people.
A lot of our work is in letting people know that the supplies that we send, they could get arrested for them.
And when you hold those packages,
Feels like a revolution.
So let's keep moving on. More states, more patients, more doctors.
I feel like the Wizard of Oz or something because I'm still behind everything.
Our biggest goal is to get the word out about access in the red states.
station a police officer at my mailbox. I dare you.
We are not going to become more quiet. We're going to become louder.
I think we're done with that one. Okay, we'll hold it then. Collectively, as intersectional feminist scholar advocates of reproduction, we've developed many tools to enable us to understand this evolving situation, some quite classic by now. Dorothy Roberts' reproductive caste system, Shelley Collins' stratified reproduction, the work of several generations of feminist scholars on the politics of reproduction since Faye Ginsburg and I grabbed that title for our 1991 annual review of anthropology chapter. All of you gathered here are part of that research workforce, laboring to bring forth our best collaborative understandings possible, especially speaking from the other side of the Atlantic at moments like this. And at the risk of hyperbole, make no mistake, it's coming for you too, albeit right now in a kinder, gentler form of abstaining from votes to protect women's access to abortion and supporting the tracking of its demographics among Rishi Sunak's cabinet members. Next slide, please. We join law professor Michelle Goodwin, who wrote in Policing the Womb, "To be pregnant and poor in the United States is to play a game of roulette with one's privacy, presumed confidential relationship with medical providers, and basic constitutional and medical rights." Slide, please. The same must now be said and highlighted for disabled people, who make up 25% of the US population by census count, and probably about the same here in the UK. Disabled women now get pregnant at the same rates as non-disabled women, and they too have both ordinary and atypical reasons for seeking terminations. As bioethicist and disability scholar Liz Bowen writes, quote, "We are far past due for a reckoning of what reproductive justice requires for adults with disability. For many of us, it means affordable, accessible, and safe abortions, whether or not we eventually want children. Disability is as varied as the human condition, and many disabled people build thriving biological families that flout ableist assumptions about who can be a parent. But at the same time, certain conditions can make pregnancy extremely high risk and physically torturous in the ways that restrictive state laws disregard. Since Dobbs, we have multiple media reports of healthcare providers delaying medically necessary abortions out of fear of lawsuit or prosecution. This disaster is compounded for those with chronic illness and disabilities. Medication and hormonal changes associated with pregnancy, for example, pose real risks of relapse and psychiatric crisis episodes for some. Kidney disease and neuropathy may be exacerbated for diabetics who are forced to bear pregnancies they didn't choose. Liz Bowen goes on to note that, quote, "The fact that the physical stress of pregnancy could take years off a chronically ill person's life would be of little or no consequence under Mississippi's abortion law." That's the case that brought down, that's Dobbs, the case that brought down Roe. For example, which contains a quote unquote life of the mother exception only in the case of a medical emergency that necessitates the immediate performance or inducement of an abortion. As sociologist Claudia Malacrida succinctly puts it, women with disabilities are at once woefully underserved and over-surveilled. Their mothering is subject to eugenic contempt, the too recent haunting of sterilization, and cultural invisibilization. Yet their conditions of impairment are overwhelmingly assumed to make them incompetent as mothers, even as they are caught in the multiple traps laid by Dobbs. In the US, disabled people live in poverty at twice the national rate, cannot accumulate savings when and if they are able to work due to the cruel and outdated asset limits of government supplemental Social Security income. Many also find travel inaccessible, prohibitively expensive, and even dangerous. Should a disabled woman have to seek an abortion out of state, she is likely having a hard time to ensure an appointment at an accessible clinic. And Black disabled women are particularly vulnerable to harsh treatment by police, who too frequently assume that the medications they might be taking, like the common arthritis medication methotrexate, are actually illegal drugs. To add life-threatening insult to injury, some doctors and pharmacists have refused to refill prescriptions for this and other pain-reducing medications since Dobbs. Liz Bowen goes on to say, the disability bioethicist, even before Dobbs, law enforcement targeted people whose miscarriages they alleged were linked to drug use, overwhelmingly charging women of color. It is chilling to imagine how this practice might intersect with disabled people being forced to carry pregnancies while dependent on medications that pose risks to fetuses. It's easy enough to profess to care about disabled lives in utero, but it's time to start listening to us about what we also need outside the womb. And inside the womb, Pregnant women, their supporters, and medical providers are forced into polarized understandings of disability by state-level political battles I've been describing. The most dramatic and well-publicized instance of this enforced polarization is found in the case of Kate Cox, whose fetus in her third pregnancy was diagnosed as having chromosome 18, widely described as a condition causing multiple structural anomalies and having no chance of survival. I'll come right back to this particular diagnosis, but first, let me continue Kate's story. Although her doctors told her she would be unable to obtain abortion care in Texas because of the state's bans, Kate, whose prior 2 children were delivered by cesarean section, faced a likely 3rd surgical birth, placing her at high risk for uterine rupture, hysterectomy, and lessening her ability to carry future pregnancies if she continued this one. As a white, blonde woman wanting a large family, Kate's was the perfect test case for challenging Texas's narrow exception clauses, and lawyers fought her case on grounds of fatal fetal anomaly as well as bodily harm to the mother. The courts flip-flopped back and forth as Kate's pregnancy progressed. She ultimately flew to New Mexico for abortion care while losing in the Texas courts. There was a national outpouring of sympathy toward Kate, who was invited by Jill Biden to attend President Biden's State of the Union address after her horrendously public struggle. Hardly noted in all the public discourse was the slippage among fatal fetal anomaly, inevitably fatal, no chance of survival, and if she survived birth, this newborn would surely suffer only to die. While such language was deployed in the face of draconian and cruel reproductive healthcare restrictions, it also masks some very complicated issues. Kate Cox's fetus seems indeed to have had a very severe diagnosis, yet the expression of chromosome 18 is extremely heterogeneous. A high percentage of fetuses with this condition will spontaneously abort. Those that survive birth often die during the first year of pregnancy. And yet, the survivors of all these vulnerabilities go on to live meaningful lives. To be clear, I, of all people, am not suggesting for 1 minute that Kate Cox should not have sought an abortion for this condition. I am, however, pointing out that the extreme conditions over which her rights to abortion care were fought out made it impossible to discern how the necessary medical legal language muted any public discussion or tutelage about how people living with this condition and their families and supporters might be faring. It is hard for someone with a recently diagnosed fetal disability to find the calm space of reflection or take the time to learn from families living with members with the same or similar impairments when they are operating under the unstable, chaotic, and frightening shadow of punitive legislation barring them from deciding what the best course of action is for them and their families. Yet in our necessary rush to defend the right to abortion decisions and care, we are also muffling the development of any public understanding of what happens when families do welcome disability, to use Alison Kafer's felicitous construct, learning to live with the full spectrum of human body-mind differences, and that synthetic word body-mind, beyond Cartesianism, is owed to Margaret Price, another disability scholar. Many feminist disability justice activists have worked to understand and lessen the tensions between support for both reproductive and disability justice over the last several decades. Now, the necessity to both fit into and challenge reasons for seeking abortion care after prenatal diagnosis may be polarizing positions which we surely want to hold together. Next slide, please. Excuse me, 1 sip of water, lest I cough at you. At the very least, the Cox case and others like it have pushed frantic consumer demands for earlier prenatal tests, often weeks before they become accurate. To spell out this dilemma, multiple screening and diagnostic technologies only yield correct results at certain points in the development of a pregnancy. Maternal fetal cell-free DNA screening, for example, its accuracy begins at 10 weeks. Chorionic villus sampling can be performed at 10 to 14 weeks, amniocentesis at 15 weeks and beyond, and full anatomic ultrasounds are accurate at 18 to 20 weeks. Before those test-specific dates, each will yield unreliable results. Thus, fetal diagnosis by serum screening, ultrasound, or invasive procedure is likely to occur well into the second trimester, sometimes near the point of fetal viability. Even before 2022, when Dobbs came down, many pregnant people described the stress associated with racing the clock when faced with fetal anomalies and gestational age restrictions on terminations. Moreover, restrictive states have very narrow and vague exception rules of what constitutes a threat to a pregnant woman's life and bodily integrity. Some also legislate reason bans, meaning that a pregnancy cannot be legally terminated in that state after a specific diagnosis, like, for example, Down syndrome. Now, post-Dobbs, the clock has stopped or is ticking faster or is even running backwards, depending on which test suggests medical follow-up for your pregnancy. In this chaotic environment, it becomes harder than ever to explain the difference between a screen and a diagnostic test, or the varied positive predictive values of each particular diagnosis, depending in part on its frequency in the given population, which for rarer conditions may only be incompletely known. So these are three obvious terms on the slide. A screen will tell you if your risk is heightened or reduced in relation to the demographic category to which you are being compared, i.e. pregnant people of your age. But it is not a diagnosis. It will move you into a higher or a lower risk category. That's all. And there's a lot of confusion about that and a lot of reports of people aborting on the basis of a higher risk screen. That's devastating. A diagnosis, on the contrary, which can be done by CBS, amniocentesis, and some sonograms, detects specific conditions with a high degree of accuracy. But even then, with a high degree of accuracy in a diagnosis, you need to think about PPV, or positive predictive value, the proportion of positive test results that are actually truly positive. That is, if you're told that something is 99% accurate, you still got 1% out there. If you're talking about a common condition, that's a big load of diagnoses, right? So it's really a statistical understanding, which is very hard to convey to most people, especially if you're anxious about your pregnancy. We're talking about the likelihood that the prenatally tested and diagnosed condition actually occurs in the newborn. And as it turns out, physicians have long tested poorly on understanding and explaining much of this knowledge to their patients, even as more and more prenatal tests flood the market, and in the United States, which is the wild west of prenatal testing, and where you can get any test you want if you can pay for it. This is an enormous problem. We can only imagine what this means for anxious pregnant women and their supporters, especially for those with low scientific literacy. One maternal fetal medical specialist commented on this confusing acceleration to test. You can bet those aren't our low-income patients asking for early testing. Whether or not low-income women or richer and more highly educated women can procure early testing, and whether or not their results prove to be correct, this is surely an instance of stratified reproduction under extreme pressure. In April, I spoke with a highly knowledgeable physician, Asha Talati, at the University of North Carolina Medical School. She's an obstetrician, a specialist in maternal fetal medicine, and a geneticist, part of a team of high-risk pregnancy healthcare providers. She told me that the Dobbs decision had thrown the field into chaos, depending on state law, regulatory mechanisms, availability of prenatal clinics, or safety net hospitals, which will take poor women in or poor pregnant people in, even without insurance, and the range of healthcare providers who may or may not be able to offer, interpret, and counsel genetic testing results in the current political economic climate. She went on to say, our Black and Latina patients and those living in rural areas are less likely to access genetic counseling and prenatal screening, and abortion restrictions will most likely impact these more marginalized groups, adding additional burden to existing disparities in maternal and newborn morbidity and mortality and in insurance coverage. The intersection of existing racial disparities and abortion restrictions will probably worsen the health of marginalized groups, and diminished access to genetic services and abortion has the potential to concentrate some disabilities in vulnerable groups, thus contributing to disparate outcomes for generations. Bans and restrictive laws too often bar their health care providers, from genetic counselors to OB nurses or midwives to physicians specializing in high-risk pregnancy who may be taking care of vulnerable pregnant women, vulnerable fetuses, or both, from conducting the conversations they need to have. One Texas obstetrician, for example, said of the vague and controversial Texas fatal fetal anomaly laws that the physicians negotiating over what constitutes a severe enough prenatal diagnosis to justify a pregnant woman's abortion, and these were all the ones that were invoked, denied, appealed, overruled in Kate Cox's case. This person said, we need support rather than being threatened. In a cancer treatment, they don't need to ask 3 other doctors to certify before they do the right thing. That heartfelt plea echoes through the Medical Integrity Project, a collaboration of public health physicians and lawyers that brings together many relevant professional medical associations of obstetrician gynecologists, pediatricians, oncologists, psychiatrists, family medicine specialists, geneticists, and more. This research and policy project focuses on documenting the experiences of those with pregnancy complications and the physicians who take care of them in ban and restrictive states. Its title, Medical Integrity, highlights how post-Dobbs restrictions constitute an assault on medicine itself and on the science that underlies it, as well as institutional obligations to patients' welfare as a priority. Medical integrity researchers are addressing the collateral damage caused to physicians as well as their patients in order to develop policy resources and publicity to help resolve conflicts and ensure that patients receive optimal care. This work in support of physicians being allowed to use their professional judgment in serving pregnant patients faces difficult choices, and it contrasts markedly with some conversations reported to me by younger physician colleagues about their older and old school male obstetricians in Ohio, one of those states that had the referendum, which then legalized after illegalizing abortion. It had a lot of court wins, but it's very confusing. These guys were reported, they commonly say things like, why send her for genetic counseling? It's a waste of time and money, and she can't get an abortion here anyway. Yet among those younger physicians from whom I've heard these stories, there's a lot of network sharing as they search for ways to refer to abortion-protective states where their former medical school friends now work, hoping to find a path for a pregnant patient facing what is so antiseptically dubbed a positive prenatal diagnosis to get support. There, some physicians and nonprofits are arranging what get called package deals that may provide anything from discounted medical services, which doctors provide pro bono by charging only for clinical time, and possibly hotel reservations. These all have to be paid upfront in cash. I've heard informal reports of these deals from high-risk pregnancy physicians in New York and in Connecticut, states that protect abortion care. None of this, of course, is covered by a pregnant person's insurance, which is subject to her state's law. So abortion funds are critical, to say the least. The National Network of Abortion Funds is a venerable advocacy project dating back to 1993. It brings together over 100 nonprofit funding initiatives, many serving rural counties and states. In the first year after the Dobbs decision, new chapters of NOF opened up, and contributions to both national and local funds increased dramatically in an outpouring of rage, grief, and practical action as soon as Roe was lost. There was also an immediate 39% increase nationally in requests, and the fund supported over 102,000 abortion seekers that year, the first year post-Dobbs. Abortion funds also increased support for logistical needs like transportation if you have to get out of your state, lodging if you have to go to another one overnight, childcare, and more. By the second year, however, fund contributions were staggeringly down. That's the language of the National Network for Abortion Fund's executive director, Oriaku Njoku. This, of course, is a very worrisome situation. Now, more and more pregnant women have needed help in leaving their states, and inflation has hit the travel and hotel industries. The needs continue to rise, along with many of its ancillary costs, supporting those who must travel increasingly long distance as southern hubs like Florida revert to a 6-week abortion ban, and North Carolina, considered a middle liberal state, holds the line at 12 weeks, referring many to Washington, D.C., which is within driving distance for later abortion care. Many activists are hard at work campaigning for donations, trying to keep this ongoing need in public consciousness as the demands of other violent and threatening national and international situations vie for first place. The impact of this dramatic increase in need for travel for abortion care is only beginning to be tracked in the U.S. Yet there are long-standing models here in the UK and throughout the EU where gestational age restrictions have sent women across borders for decades, especially but not exclusively for later abortion procedures not permitted in their home countries. Interdisciplinary teams of social science, research physicians, public health analysts, including anthropologists Joanna Mishtal, Silvia DeZordo, and Giulia Zanini, have tracked how women find their sources of information, financial arrangements, including insurance coverage and travel, all the while querying the experiences of those traveling from France, Germany, Italy, and Ireland to seek abortion care in the UK, the Netherlands, and Spain. We should note, of course, the immense and comprehensive Irish abortion legalization victory. It's something to celebrate. Yet it still entails a gestational age limit of 12 weeks with some fetal anomaly exceptions. And pregnant Irish women still seek abortion care abroad after that time frame, albeit in much smaller numbers. These researchers' takeaway message stresses the importance of the management of information, or misinformation in the case of the United States, as key for those seeking abortion care in reproductive governance regimes more liberal than their own. This will surely be true in the banned state restrictions of America, where many health advocacy organizations and abortion funds like Plan C try to provide comprehensive and accurate information through websites and helplines for self-managed medication abortion. Next slide, please. But the internet can also be overwhelming as well as helpful, especially for those without great familiarity with its resources and spotty access to them. The web itself can become a form of abortion governance, what medical law researcher Ruth Fletcher over a decade ago called peripheral governance. Once again, stratified reproduction through stratified web access. Yet this issue now lives squarely on the web, where new Jane models are being uploaded at vigorous rates. So let me back off and tell you what Jane is and show you yet another clip. Jane was an underground abortion network founded in the mid-1960s in Chicago by women who said enough is enough, and they figured out how to work with a team of physicians who were willing to practice abortion illegally there, and they worked with different citizens living in Chicago who were willing to volunteer their houses. So what you would do is get this little, you're not old enough, many of you, to remember this, but before the internet, you'd have these paper signs with little tags that you'd tear off, and it would say, pregnant, call Jane, and they'd give you a phone number, and you call Jane and say, I want to talk to Jane, and then they'd get you information on abortion. So maybe we should just show the clip.
We were ordinary women trying to save women's lives, but we were criminals. We were felons.
most of the nation. In 72, abortion was illegal.
We had to go underground.
The woman would be given the address to the front.
It was probably obvious to neighbors what was going on.
We came to the surface from other things, the anti-war movement, the civil rights movement.
You couldn't not pay attention to what was going on.
Fetal death is murder.
You could not work as a pregnant woman. If you weren't married, you were out of luck.
They were terrible situations.
The septic abortion ward was full every day.
Women did awful things.
They were literally dying because they were women.
So we thought we can be of use. I said, we could use my phone, but change it so that they don't ask for Eleanor. How about Jane? Nobody's called Jane anymore.
We had the phone numbers on bulletin boards around Chicago. Pregnant, call Jane.
The clientele included daughters, wives, mistresses of police, state's attorney, judges.
It dawned on me how big an issue this was.
Jane was an outrageous undertaking by a lot of smart women.
I was
And
not
very
there to
young
pass
women.
judgment.
I knew there were women like me. Under the radar of the Chicago Mafia and police department.
We were all being watched.
The phone rings. A man says, we know where you are.
There were 11 counts of conspiracy to commit abortion. 110 years for each of us. So that's a long time.
That might have ended Jane right then and there.
I couldn't see myself sitting on the sidelines.
We were building a new world, one woman at a time.
Sometimes you have to stand up to illegitimate authority. And sometimes there are unjust laws that need to be challenged.
So that's our honorable history. Let's leave that slide up for a moment. Thanks, Lucy. Whoops. Go back to the other one, please. If we can stop it from playing, let's see. Yeah, if we can keep it there. All right. The new Jane models have been popping up everywhere. Activists, many internationalists, beginning, of course, with Women on Waves, now also Women on Web, initially based in the Netherlands, and more recent women's health initiatives that send abortion medication from Mexico. They've all taken up the message to provide these resources, both with and without medical consultation attached. There are many practices of resistance and hope across the country, much of it website accessible. Some are long-standing, others are creatively new since Dobbs, and many involve traveling pregnant people and abortion medication. I've presented a lot of dire information on this chaotic and punitive state of reproductive health care in the US, its profound stratification by geopolitical jurisdiction, urban-rural divides, wealth, and ableism. I hope you've also picked up some of the glimmers of hope in my examples, as many healthcare providers, women's health and advocacy groups, legal teams, and media activists are fighting back. Hopeful projects are everywhere once you start to look for them. In the huge outpouring of the woman's vote whenever the issue is on the ballot, in new abortion funds, new Janes, Plan C, the constant protests in red states, in the Medical Integrity Project to support physicians dealing with emergency pregnancy care. And despite the gravity of the situation, there are moments of down-homey humor and gumption for which America's heartland is renowned. Next slide. Oops, there it is. There's a support of an abortion fund called Abortion, You Betcha, which is one of those quintessential Midwestern expressions. Here's the example. My dear friend and co-author Faye Ginsburg wrote her dissertation and first book on the controversy surrounding the opening of Red River Women's Clinic in Fargo, North Dakota in the 1980s. After Dobbs, she caught up with some of the health activists she's interviewed many decades before. Red River had long been the only abortion clinic standing in North Dakota, a very conservative state, and with typical can-do foresight, its nonprofit staffers began raising money to move the clinic across the state line to Minnesota, a much more liberal state, before Roe fell. They launched a GoFundMe campaign to cover moving costs. They were raising money with t-shirts and sweatshirts. Their goal was to raise $250,000, $250,000. It's a lot of money. Instead, donations totaling over $1 million poured in. Abortion, you betcha, indeed. There are many more projects of advocacy and resistance than I've got time to mention in my one brief talk. Actions are taking place among public health researchers, media makers, performing artists, and more. And some are, well, highly unusual. Among the most recent creative and unusual activists, there's a group that calls themselves Elevated Access. So if we could have the last clip.
Presenting Elevated Access. We believe everyone deserves access to healthcare. Our volunteer pilots transport passengers at no cost to access the care they need. 14 states have complete abortion bans. Additionally, 19 states have bans on gender-affirming care. Millions of people today have to travel across state lines to receive life-saving health care. Less than 18 months since our founding, Elevated Access has already recruited over 1,350 volunteer pilots.
I was gonna go fly today anyway, so I might as well go fly and get somebody the care they need.
At some other stage in my life, I needed abortion care, and I know that feeling.
A pilot can take off from any airport, and it seems appropriate to me to use that freedom I have to help people whose much more fundamental freedoms, the freedom of bodily autonomy, is being infringed.
The passengers don't have to pay a dime. What it means to give somebody the opportunity to receive the help that they need, that's priceless to me.
We work with more than 80 trusted organizational partners who refer passengers after determining a good match for our support.
Our typical client, I would say, is a woman of color who is a mother to 1 to 3 children. They are very low income, if any income. Some of them are fleeing domestic abuse situations. They know they need the abortion, they know they need the health care, and they've made the decision to have one.
That was a long day, but it would have been even longer without the help and generosity of everyone at Elevated Access. We had to travel 2 states over, but we received education from a professional today who answered our questions, which will help us make informed decisions in the future.
In our first 18 months, we traveled over 250,000 miles and provided over 400 flights. And in the month following that, there were another 100 flights completed. Our need is growing daily, and our team is expanding quickly to accommodate the requests. You can help. Get involved today.
Stratified, overground, underground, indeed. In sharing this clip, I intend to leave you with a literally uplifting practice of hope. Grassroots and sky-high resistances everywhere, but across all our geopolitical stratifications of age, class, racial, ethnic, religious, ableist differences, we face an intransigent battle to protect the reproductive health of everyone, every one of us. Thank you for your interest. Okay, Lucy, what's next? Am I supposed to sit here?
Thank you so much. Yeah, go and sit down. And there's an opportunity for all of you to give a response or to ask some questions and maybe to talk a little bit about what the situation is here in the UK in response to what's happening in the US. Is there anybody who feels called to start with something. And I think we have Marina in the back with a roving mic, so that's great. Yes, here's someone at the front.
Thanks so much. That was such a wonderful talk, and to get such a good overview of what's going on in the US. I'm from Australia. I just flew in a few hours ago, so if I can't articulate myself, that's why. I'm just wondering if you can speak a bit more to what's going on with the IVF situation in Alabama. Is it?
Well, as of now, it's legally protected because the state legislators were laughed out of existence, so they passed emergency legislation that stabilized protection for IVF, but it will be a strategy that is used elsewhere. And it's a complicated issue because there's a lot of money in the IVF industry, which is going to help to carve out an exception for IVF, basically. You can stay tuned, but my guess is that IVF will get protection, both because it truly is appreciated by people who have faced infertility challenges, but also because there's money for the legal court battles involved at every state where it has been banned. So technically, it's state by state, but we'll see what happens in that larger picture. I don't know if that answers your question.
Yeah, I didn't realize that overturn. I didn't understand what would be the implications of the tissues.
Well, had that Alabama Supreme Court finding that it was manslaughter, involuntary manslaughter to break a test tube with a frozen embryo, had that stood in Alabama, it would have immediately been challenged, but it would have made its way up through the court system. And of course, the fear was that it would get to the Supreme Court, which is extremely conservative, pro-life, and then we would see what happened, you know. But even conservative pro-life people often support IVF. Unless, of course, they're going to go with the Catholic teaching, which is this is an impermissible sin as well. So there's a lot of gerrymandering going on.
Thank you.
Of course.
Great. Roisin in the back. Oh, and if you could say who you are, that would be nice, so we know who's in the room.
Sure. Roisin Weinfled from the University of Essex. Thank you so much for that wonderful talk. And I was really interested that you drew parallels with the Irish context. And I'm originally from Ireland. And we know from the Irish context that in the absence of abortion provision, transnational relationships became really important in terms of building new solidarities. And I was wondering if you could say whether you see something similar happening in the US.
I think that's really important, and that's exactly what I was trying to sort of tacitly point to. I think it's early days still for us to know how much travel or mostly medication through the mails is going to have to occur from other parts of the world, not only other parts of the country. It depends a lot on how much worse it gets at the Supreme Court level. Let's say that discourse is shut down. I can't imagine they can win on First Amendments, but I never imagined any of these things could really happen. So a First Amendment would mean that you can't even talk about something, that you don't have free speech to discuss abortion as a physician or an NGO trying to help individual pregnant people. If that goes forward, let's hope not, but if that were to go forward, then I can imagine those international relations being the only place or one of the few places you can actually at least get information on the realities of how you get abortion medication or where you might need to go if you're too late in your pregnancy for abortion medication. So I think that's part of what's coming for us. And good on you for the Irish Challenge. I mean, that was an extraordinary campaign and it's had an amazing effect. But even in Ireland, there are still exceptions where people have to travel. So.
Thank you.
Sandy, go ahead. Marina here in the front. Thank you. We just have to wait for the microphone so the people online can hear it too. And for the people online, if you have a question, you can put it in the chat. So feel free to participate in that way.
Thank you. I'm Sandy Starr from a charity called the Progress Educational Trust. The lack of nuance you described in discussion of prenatal tests and their reliability and so on, to what extent is that entirely or largely a byproduct of this pressure cooker, this sort of ticking clock caused by the abortion restrictions? And to what extent is it a more general problem that the abortion restrictions are simply intensifying?
It's a very good question. I tried to kind of indicate that there have been decades of work in which reproductive liberty feminists and disability feminists have come together, have cried together, have screamed at one another. I mean, there has been an intense set of struggles in America, and I think elsewhere too, to try to hammer this out. And on the whole, most of the women's health movement, maybe not everybody, but most of it, is very, very careful and supportive about how reproduction and disability intersect. That said, what's going on in the country in general is longstanding. The discrimination against the eugenic thinking around disability is longstanding, and the tests were always hailed as an unmitigated good until there was a reaction to that. So there is still a lot of work to be done, and I guess the argument I'm trying to make here is that the work has been forced to go backwards by the current moment and situation. That is, since the passage of the ADA, the Americans with Disability Act in 1990, which gave adults, not only children in school, but adults their full civil rights in America when they had a disability, and which led to everything from ramps and, sound surround speakers and all the technology, but also I would say to a rising public consciousness around disability, which is a really important fact. When Faye and I started doing this work, you couldn't find very much about anybody but children in the disability literature. I mean, all the medical literature, all the legal literature focused on children. And yet the role of adults with disability is phenomenally important in how disability rights have been won and how they are being defended at the present moment. So there's like several mobilized histories there of women and healthcare, of families and education and disability, of disabled adults who have grown up in part, this is an ironic statement, right, due to the benefits of modern contemporary medicine, which has made it possible for people who might have died three decades ago, and certainly people who were institutionalized before deinstitutionalization in the 70s, the 80s, and forward. It has made it possible for there to be several generations of adults, disability scholars, activists, advocates, people living their lives, who make it possible to say, it's not so simple as we should get rid of all disability. Right? Disability in and of itself is not the problem. The problem is social prejudice and the structural barriers. At the same time, speaking as a reproductive healthcare advocate and activist, you never want to say, and therefore don't have prenatal testing. Nobody is saying that. Nobody at all is saying that. But how you then, that is, who's in the advocacy movements, plenty of people are saying that if they're in the anti-abortion movements. But how you then reconcile those forces, how you live with those constraints and contradictions and kind of tensions, that's the work of public education. And it's always, 2 steps forward, 1 side, 6 back. And this is a moment when I think there's a lot of backsliding because the need to defend abortion after prenatal diagnosis is so profound in the banned states or the highly restrictive states which put abortion at 6 weeks, at 8 weeks, at 10 weeks on the docket. And of course, the prenatal tests, as I tried to explain, take place much later than that in a pregnancy. So I just think the clash around abortion is forcing us backwards in how we think with more nuance about disability.
Yes, Anne, go ahead.
Hi, I'm Anne Pollock here in Global Health and Social Medicine at King's. So thank you so much for this talk that I think did such a beautiful job both of really honing in on the context around abortion right now in the United States, and then also putting that into relationship with disability studies. And of course, this is something that we've all long admired in your work. I guess I wonder if you could say a little bit more about that way in which we've been pushed backward into focusing on abortion as an isolated issue. Because it seems like one thing that is still missing here is understanding why are people not having access to contraception? Why are they not having access to the ability to control what's going on with their sexuality that may or may not be this may or may not have been an encounter that was desired, right? Freedom from sexual violence, freedom from the need to rely on sexual, kind of sex work for survival, all sorts of issues that feel like they get also occluded when we look only at the ability to access abortion, which of course we also need. And so I wonder if you have thoughts about the broader context of gender equity, sex equity, and how this fight over abortion is both a side of that, but may also obscure that.
You're absolutely right about the list of other forms of sexual, relational understandings of the body and what is happening to individuals and to whole groups of people. And some of that is around the other place where this is all taking place, of course, in the United States, is around the treatment of youth who are trans youth. And you could see that in that last clip, or that's also been mobilized by all the very, very conservative states. And basically, it is that whole bundle of issues that you just moved to talk about. Contraception, there is a huge fear. Most of the justices on the Supreme Court at this moment are Catholic, and many of them are renegade Catholic. They come from very, very particularly conservative sects within Catholicism. So the question of what will happen if contraception comes up, Clarence Thomas has basically said, contraception goes next. He said that publicly. So these things are all on the docket tacitly. Whether they will actually rise to the level of court decisions or not, you've already transformed the socio-cultural environment in which those discussions are taking place. And that's really part of also, as I tried to indicate, saying that the conservatives, not only on the court, but at the state level, are really out to gerrymander the vote to make sure that anybody who is likely to vote on the liberal side of any issue, whether that is contraception or trans medical care or anything, sex work, as you mentioned, all those things are coming under scrutiny by the idea that you can if you can't stop them from voting for progress on any of these issues, for liberalizing the agenda around bodily autonomy, and protection of the vulnerable. If you can't stop them from voting for it, you can stop them by gerrymandering the vote in the first place. So that is really where a lot of the struggles are. And I'm not a legal scholar. It was of no interest to me until it was pointed out, however many decades ago, that we were going to lose it all unless we paid attention to what was going on at the legal level and at the state level. Not only, I live in a bubble, I live in New York City. It's very protective, but that's not a bubble that extends to the country or across national borders or to many parts of the world right now.
Thank you, Rayna. There's a woman over there with green and black.
Yes, Sarah Johns, University of Kent. This is sort of almost a follow-up question. Like you mentioned, the socio-political landscape has changed. Now it's sort of 2 years post-Dobbs. What is known about the children that have been born who essentially were not aborted? Has there been a rise in infanticide rates, child abuse, maltreatment? What sort of is going on in that sector?
We know nothing. The answer is there is no data on that question. It's a really important question. Several of the OBs the kind of high-risk pregnancy physicians that I interviewed when I was getting this talked together said essentially those babies are just being born now, especially the ones who came over the Texas border and were then shipped to the Northeast as a political move by Greg Abbott, the governor of the state of Texas. And a lot of those pregnant women who came north already had so much stress. They had preeclampsia or frank-eclampsia. They had horrible medical conditions which were going to affect the outcome for them and the outcome for their fetuses in utero as well. We have no data on that. We just know those babies are getting born now. And some of them are babies that may have ended up being aborted based on prenatal diagnosis, but the vast majority are just going to be babies that maybe wouldn't have been born had there been adequate contraception or abortion care available to those people as they lived in red states or moved into red states as they crossed the border. So stay tuned. Somebody must be tracking this, but I wasn't able to find them yet. I think it's just early. It's just starting.
Great, and we can go to Mara in the back in red. And then we also have some questions online. So after your contribution, we'll go online as well.
Okay. Hi. Mara Clark. I started the first abortion fund in Europe and currently work with Supporting Abortions for Everyone, which is based in the Netherlands. And Lucy planted me. So what you said, first of all, as a disabled woman, thank you very much for really like pounding on the ableism and all of that. But also, it's really easy for us in Europe to think, well, that's over there. But it's really not. It's really over here. We've seen a massive increase in prosecutions of women in England for doing their own abortions outside of the healthcare system. Scotland and Wales have to ship their women to England to have abortions over 18 weeks. Pregnant people in England have to travel long distances. Women in Ireland are still traveling 20 a month. Italy has 72% of doctors who conscientiously object. That's 100% if you go to the south of Italy, Hungary, Romania, Spain. Everybody's celebrating France putting abortion in the Constitution, but abortion's only available up to 14 weeks. And nobody knows. We're frogs in the water, and we're looking at America and laughing and saying that's never going to happen here because we're Europe, and there's also a funding crisis because all of the European foundations are sending funds to the US and to global majority countries, which, by the way, we don't argue with, but there's a real problem here, and the victory in the US is shoving more money into these organizations that are against not only abortion, but all bodily autonomy. So I just wanted to take the opportunity to tell everybody that, as Rayna said, you know, they told us 20 years ago in America, we were saying this is going to happen, and everybody told us we were hysterical. And now they're hysterical, and we're like, well, welcome. But where were you 20 years ago?
Thank you so much for your good work and also your harrowing statistics. And the piece that I have no knowledge of is the emptying out of some of the funds in Europe to provide access to the US. That in and of itself is extremely sobering. So thank you for teaching me about that. I'll go looking for it as well. I mean, it is an international interlocking system, just as it is a state-by-state system in the United States. It's states at the national level that are both in support of one another and in conflict with one another. And we're all kind of guinea pigs in that system as it runs its course. So yes, I think the situation here is going to get worse before it gets better, although maybe you'll have better organization than we have had in being able to fight it. I wish you good luck.
Well, we have some people online before we go to the back, and then we only have a few minutes left. So I'm going to do the two online questions in one go. There's someone called Dieslinko, and they ask, do you see the recent constitutionalization of abortion access in France having an impact on discussions in the US or internationally?
Can you say it again with the microphone less close to your mouth? I can't understand what the question was. Sorry, Lucy.
No, don't worry. So it's about whether you see the recent constitutionalization of the right of abortion access in France as having an impact on the discussions in the US.
Probably not, because Americans are oblivious to anybody outside of the United States. I don't say that lightly. It's a terrible problem. Foreign policy, people don't want to know in the US. We are a very isolationist nation. And so, yes, I wish that the French move had more impact in America than it has had. And thank you for your question. And maybe we can find a way to make it have more impact, but no, not yet, at least.
Okay, and then we have another one by the wonderful Lucy Yanov, who we all miss, who asks, I am curious if you think there may be a care ethics reframe of genetic testing that might be mobilizing in the US, where genetic testing could be reframed as a prenatal tool to prepare care for an impaired child. Curious if you're seeing this in your discussion with US providers.
Wow, I have 6 papers I want to tell you about. This is such an important issue. I work with a group called Prepare, which has NIH funding now finished, but starting to go after the next round. It's been for about 5 years. It is a group that comes out of Case Western Reserve in Ohio, that state where they banned and then they legalized and they put in the Constitution and then they illegalized and then they re-legalized, out of Ohio. And it is testing a model of whether prenatal genetic testing ever is used, but empirically, by people who get a prenatal diagnosis and decide to continue the pregnancy. Mostly people who are anti-abortion never go for prenatal testing, and most of the advocacy support groups, Down syndrome, chromosome 18, spina bifida, a whole bunch of ones that are far lesser known. There are 400 or 500 of them that are in something called the Genetic Alliance, which is a kind of advocacy front within, just adopted about 10 years ago, inside the National Institutes of Health. But there has been long the claim that prenatal diagnosis is not just about abortion, it's about preparing families should they have the birth of an atypical child and they need some time to get used to it and to marshal their resources. But there's no empirical information. So this is building models for how you work with the support advocacy groups for the families, the clinicians who take care of people, the legal structure, the medical researchers. And our work was done in, I think, 5 states, which ranged from kind of rural Florida, which is mainly low income Black Americans and Spanish speakers, to the heights of New York City, where you've got both very, very rich and very, very poor women getting prenatal diagnosis, to we had a hospital in Ohio, obviously, and one else in, I think, Tennessee. So trying to find out empirically what it is that we might know about what pregnant women, people who get a prenatal diagnosis and decide to continue a pregnancy, how they would understand what they want and how we can best design policy and resources so they can get the kind of support they need and make it accurate that prenatal genetic testing is actually useful to a range of people, not just people who might decide to end a pregnancy.
Thank you. There was someone in the back.
Hi, my name's Cami. I'll be doing a PhD in women's health at UCL in September, which is very exciting. And yeah, thank you so much for your talk. It was so informative and I think had a really good combination of different lenses, which is kind of what my question is about. Like you highlighted, it's really important to have lots of different people from lots of different industries and backgrounds coming together, especially in women's health. We need doctors, we need psychologists, we need sociologists, anthropologists, lawyers, pilots even, to help with the efforts. So what kind of thoughts or recommendations do you have to help unite all these different disciplines and industries to kind of come together for the greater good and the kind of joint cause when there are often such differences in processes, perspectives, approaches? What's kind of your thoughts on that?
Well, I don't think there's an easy answer to that that's a unity answer. I think some of these projects are exactly the way that you're describing them interdisciplinary, interprofessional, intercongregational in the case of religion. There are so many projects going on, and yet they face such enormous challenges. Not the least of the challenges, speaking to somebody in, say, sociology or anthropology, is the state of funding for research. I mean, I was trained, we were talking about this at lunch with Rashida and Shagufta, about the way in which anthropologists didn't get any much in the way of methodological training in my generation. We just were sink or swim. Maybe the guys went out for drinks with their male professors after classes, but we sure weren't invited. And we just went to the field and did whatever we did. Now we try to train our young researchers. We try to give them the kind of support they're going to need to get through field working and empirical methods and suggestions. But also, because of the state of funding and the state of methodology, it's also important for people to be trained to think interdisciplinarily and to be able to work in collectives and teams. And within that, speaking as a qualitative social scientist, you're at the bottom of the heap. You know, statistics and the people who do big-time numbered research always end up at the top. And a lot of the methods that we use, which are in some senses slow methods, not fast methods. We go out and we actually hang with people long enough to gain the possible understandings of what they can teach about the issue. It becomes more and more complicated to do that kind of work. On the other hand, your generation is being much better trained than mine ever was to be able to think in terms of interdisciplinary conversations, reading one another's literatures, and also designing the kinds of research and advocacy work. I think of something like that medical integrity project that I mentioned at some point in the talk, where you've got public health people from law and medicine working together to actually go after the experiences of physicians in 5 key red states to figure out what's happening to them. Are they leaving the field? What do they need to stay in the field, and the like? But in that process, they're going to use a bunch of qualitative sociologists and anthropologists to actually do the interviews and actually code the interviews and try to figure out what's going on thematically. So there's ample room for everybody, and there's no unified strategy out there, but there are a lot of good places where people should be banding together.
All right, we're coming to a close. We have one last question from Rachel, and then we're going to go to the salon.
Hi, thank you very much for your talk. I clearly don't know how to use the mics. So my name is Rachel Sanchez. I'm a researcher at the University of Cambridge. And I was wondering, throughout your talk, you only talk about the 50 states in the United States of America. However, the United States is an imperial power with a lot of different territories that, like, at first glance, like, those particular territories might be perceived as having more progressive reproductive politics, like, because of the long history of imperialism, colonialism, and eugenic logics that have been imposed by the United States of America. So there's a lot of, like, different red states, for example, that are particularly restrictive in relation to reproduction, like Florida, that might be closer to a place like St. Thomas or Puerto Rico that already have, like, really strained health systems. So that might start to happen if it hasn't happened already. So do you know if there's any data about, like, all of those, like, logics of imperialism and colonialism that intersect with broader reproductive politics?
Boy, that's a wonderful question, and the short answer is no, I don't know, but it certainly is something that needs to be thought about. I mean, there is such a big discussion out there about the history of colonialism and what that has to do with the way in which the United States institutions, laws, healthcare systems, and the like all present themselves. So that is going to turn out to be a piece of the program too. So thank you.
Thank you, both of you. And before I thank Rayna, I want to thank all of you for being here. And I will do another little speech to give proper thanks to everyone. But for now, I would like to call attention to Chanel Scott, who's standing by the door in the back in the beautiful yellow skirt, who's been doing a lot of coordinating of all the volunteers. So thank you very much. And I also want to thank the Department of Global Health and Social Medicine, as well as the SSBP faculty for funding this, which is also part of the Reproduction Research Cluster. I'll go into more detail to thank all the volunteers and everyone involved later on. For now, one last person I want to thank is the AFV guy, who's done a great job. So thank you too for making it accessible to the people online who are also sending us hearts and are missing us. And of course, before we're going to applaud Rayna, I want to tell you what the next step is. So we will have a wonderful salon space on the other side. When this ends, you can go into the middle block where you can put on some stickers. If you don't have stickers, you can hug each other or say hello to each other. And then we should be finished in a couple of minutes' time. And we'll open up the doors, and then you can have some lovely food, some lovely drinks, and some time with each other to catch up. So, but for now, let's give Rayna a big round of applause for a wonderful talk.